Hello.
Hi, Dr. Thelma. You're in.
Yes, I'm in. I'm sorry. I do apologize. I think it tried to log me in via my personal email, but you sent a link to my OUM. Long story short, I had to go on all the angles. Anyway, I'm here.
No worries. We're glad you're here. Our attendees have been waiting patiently, so no worries at all. I want to
Yeah.
say hi to Daniel and Alina and Davis and Greg and Haliru and Helen and Ishan, Karan Deep and Liam. Hi, Linda and Mesh, Michael and Mohit and Mumtaz and Nitin. Panayati, Paul and Rianu, hi Samit and Scott, and hi Shanda and Shannon and Tadiwa and Tim and Wale. I see some familiar faces from our meet and greet last night. So welcome to new students, and I see some familiar faces of our existing students as well, and some folks that I recognize from webinars and some new people as well. So welcome everyone to our Meet the Graduate webinar. I'm Associate Professor Nicolette McGuire. I'm the OUM Associate Dean for Student Engagement. And I'm so pleased that we're able to resolve our technical difficulties and bring forward, I guess I'll cross my fingers on that. Bring
Sorry.
forward our OUM graduate, Dr. Thelma Boshoff, to speak with you today about her journey towards becoming a medical doctor in Australia. So welcome, Dr. Thelma. Thanks for joining us.
Thank you so much, Professor McGuire. Appreciate it.
So why don't we get started? Do you want to tell us a little bit about yourself, where you're from, and why did you want to become a doctor?
Okay, yeah, that's a good start. So I'm South African by culture. Obviously lived in New Zealand for a few years and moved over to Australia in 2012. I was when I came to Australia, I was actually a graduate physiotherapist, so I studied that in New Zealand, and my career just kicked off. And I guess I always wanted to be a doctor, but I took the path of least resistance because of having kids and a family. I thought physiotherapy might be a better career option for me. And it wasn't a few years into the job that I really felt I was missing the mental challenge and the clinical reasoning side of medicine. Yeah, so I kind of just thought, why not embark on that path and see how I go?
Thanks. I think that's a thread that I do hear, like people try to do other things. But it's just burning in the background. And I'm so happy that you didn't ignore that you took the steps to move yourself forward. They weren't easy steps, but
No.
that you did. So you said you were a physiotherapist before becoming a doctor. Do you think that there might be some budding physiotherapists, or there might be some physiotherapists that are budding doctors joining us via recording. Hi, if you're joining via recording. Do you think that helped you in any way get started in medicine? Was there anything like about being a physiotherapist that you think has influenced your career, your steps to starting medical school?
In short, I would say yes. And why I would say that is a lot of pre-graduates, obviously, from my understanding of the OUM, a cohort is a lot of us come, this will be our second profession or third profession. We come with those soft skills. And there's one thing that medical school cannot teach you is the experience with a patient, having that interaction. And I know there's some graduates or undergraduates, sorry, that's basically coming from a different background, like engineering or accounting. I'm particularly talking from a health science point of view. Yes, it did help me. I didn't have to overcome knowing how to talk to a patient, how to interact. That is a lot of things that the young graduates struggle with, is that that interaction of the patient, then getting the information out of the patient, then obviously gather information and history regarding that to come up with your differential diagnosis in order to manage that patient adequately. So that's one thing that you can put aside. It's in your toolbox, and a lot of feedback we get from in particular from the hospital where I'm rotating now as an intern, is they love us because we come with soft skills, we don't take nonsense, and we get on with the job. We're not as precious as per se. We're kind of ready for the job. We kind of just want to express ourselves. We can finally say we're doctors. I'm here to work as a doctor. I'm here to help. Obviously, you're junior staff, so you have to know your boundaries. But there is a cheeky here and there where, for example, at yesterday's ward round, and I'll tell you a little bit more about that. I think it's one of the questions that will be asked. Yesterday's ward round, the registrar put me on the spot, and I've admitted 2 patients earlier the week, and she said, I want you to present these cases for the consultant. And there were about 3 or 4 medical students. So we were about a team of 7. So this is a soft skill set that you come with as a previously qualified clinician.
So, I mean, definitely, like, we have students that are 22, we have students that are 62, we have students that come from health professions background, we have engineers and accountants, and, as you said, and teachers and other professions as well. And I think, one of the things that people have in common is that they have this drive and they like the model that we have, where you do the preclinical years online, and then as you move into the clinical years, you're on site, and that creates a really good setup for many people and how they want to see their lives be directed. But it also creates like a pretty diverse experience in the classroom, because you have people that are physiotherapists, and you have people that are nurses, and you have engineers, and it's like a different way of approaching the same questions. You kind of get a diversity of experience and understanding when you step into a classroom. I know that where you are now, there's actually 2 other students who were hired at the same time as you. Is that right? Is there 3 of you there?
We are 4.
Oh, 4. Well, there.
Yeah, so we're a great little OUM pack, and we're the only IMGs, from my understanding, that's been recruited out of intake of 20 people. And they absolutely love us, because I think we're also the older ones of the cohort. A lot of them are through the local university, and in this case, it's Notre Dame, University of Notre Dame. So it's a clinical, it's a teaching hospital we actually got our roles or internships with. And it's kind of interesting to see how we now interacting with a lot of students as well. We were there about 1 or 2 years ago. We know exactly what's going through their minds.
This is a question that a lot of prospective and prospective students and existing students have about the process for an IMG getting a job as an intern in Australia. You don't have to go through like the nitty-gritty details, or as much as you would like to. Can you tell us a little bit about your journey from graduating and then getting a job as an intern in Australia? Was it different because you're an IMG or an international medical grad?
I think we need to steer away from being biased, whether we're IMGs or not. I think we need to be proactive in how we try to secure those roles. It's a little bit hard for us, but in saying that, it's also as hard as the effort you put into it. I think the 4 of us were lucky, as one of the interns was doing a bit of the hard work. She was doing, trying to see whether there's any intakes. And being an intern in IMG, you can't go through the PMCV pathway, so they say. But the moment you are being secured in a role at a hospital, they very quickly put you on their list. So this is a little bit of a technicality with the PMCV, where there's a bit of uncertainty with IMGs regarding that. My advice would be is, I presume most of our students listening to this is Australian. I don't want to be assuming they're not. There might be American cohort as well, but
there are Australian students and prospective students that are here, and there's some from other countries, but they're here because they're interested in the Australian experience. So please just yeah.
I guess if you're outside of Australia as an IMG, if you can get your internship year done and at least just passed AMC 1 and 2. That's the best way to guarantee your entrance into Australia. They are very interested in IMGs. Like from what I've seen and we are bringing a lot of what do you call it, job satisfaction to the hospital cohort in general. We also come with diversity and diverse skills. Australia is one of those countries where they're extremely open to the candidate. It depends how you interview. It depends what your CV is looking like, your references. I cannot overemphasize references. Make sure you have those, have them in writing. Make sure you have, focus on your things that hospitals want to hear, like your clinical skills, your problem-solving abilities, how to deal with a difficult patient or, a conflict situation. Those are the things hospitals do want to hear. I guess in my case, I was lucky. I've been working as a physio for over 12 years in Australia. I also have my own private practice. So I've been lucky that I was using my CV as another reference point and saying, I do understand the Australian curriculum and healthcare system. I do want to contribute to the medical side of it. Will you take me? And your own letter, what you put in that letter, I would say, make sure you make it clear to the hospital why you want this role, because they're going to look, and something needs to stand out to them, basically.
Very good advice. I wonder if you might give some advice about the AMC as well. So the AMC is the Australian Medical Council exam, which is given to international medical graduates before they start practice. Well, you can tell a little bit more about that if you'd like. But tell us a little bit about preparing for that. Was it like a huge hurdle for you? Is that something people should be really concerned about? Tell us a little bit about your experience taking the AMC.
Okay, I'll give you the cowboy version. And
Okay.
everyone is listening. I basically graduated from medical school and I literally sat my MC exam within 4 or 5 weeks, and I haven't prepared. And I literally did it to see how I'm going to gauge in that exam. I know it's a very expensive experiment. It's quite expensive. It's about $2,000 or $3,000. I can't recall now. I failed that in flying colors. And then I realized that's the path I took. Okay. I wouldn't advise that anyone else take that path.
You never know. You could have
You
passed.
never know.
Yeah.
The second thing I would say is the MCQ is basically based on Australian curriculum. So you will have to know your guidelines. Your guidelines, you need to know hospital guidelines. So our hospitals, every hospital's got their own guidelines, but then you also have the GP practice guidelines. You've got guidelines, for example, on skin cancers they use from New Zealand dermatology. So Australia is very about guidelines because their hospital system works around those guidelines and their management of a patient. Murdoch is another book I studied for the MCQ extensively. There is a ratio, so I would advise, the graduates to go through the requirement on the AMC website. That is quite clear in what they want you to study for. And also be prepared, because all those answer choices, I'm just going to put it out there, all the answer choices they give you on this MCQ is the correct answer. They want to see your clinical reasoning in what is the most appropriate at that moment. So read the question. A lot of people actually fail the exams because in their mind they read the question this way, and then that was the right answer, but that's not what they wanted to see. So I guess that's how I got caught out in my first attempt. My second attempt was obviously more prepared. I also joined, there's a lot of AMC study groups going around that will be shared among students usually. The best way to approach that is just put your feelers out and join a group, because what they do is they talk about, they prepare together as a group. So there will be a sitting on Monday or Tuesday, Wednesday. In that week, they will prepare for that week as a cohort. I found that extremely beneficial.
Great. And you were able to pass, which is amazing. Okay, your current position. So tell us a little bit about a day in your life. What's a typical day as an intern in Victoria?
Um, Look, I'm not, it can be hard. I do travel quite far for work, so my commuting can be up to 4 hours a day in addition to a 10-hour shift, but it's only 4 days on. So on a day-to-day basis, basically your role as a junior doctor is that, you basically do a lot of the administration side of things, attending ward rounds, obviously referrals, a lot of internal referrals, external referrals. I actually have been so blessed to get my hands dirty with clinical skills. It depends on your registrar and consultant as well, and how confident they think they are with you as a clinician. Um, I I would also advise interns to um, take the pressure off yourself. They actually expect nothing from you. And that's the sad bit, because I feel frustrated because I feel like they think I'm an idiot, which I'm not. So I think it depends on your age group. I'm a little bit, I do actually know the answer to that differential. I do know what is the management plan for that. I think you will have to go in there with an open mind, but also when it comes to patient safety, um, you will have to always make sure you ask. You can never ask too many questions. You're always in a well, I can only speak from the hospital I'm working at, but we're in a very well supported environment. We've got protected intern education time per week. If you don't attend that, they literally chase you down the hospital and go, "Where are you?" So, these are the things as an intern that I would say relax, enjoy, because my I've seen the HMOs and I've seen the registrars. The registrars are really the workhorses of the hospital when it comes to, coming up with a management plan. The consultants obviously have it very nicely, in my opinion. Sorry, I have to put it out there. But look, the responsibility as the head of the department is out there. So my first rotation was in pediatrics. In Australia, it's actually quite hard to get an internship start or an intern starting in pediatrics, and that's the feedback I got. That's also a requirement for part of your general registration. They want you to have pediatric ED and general medicine experience and surgery as well. So those are the 4 categories you do need to tick off during your internship year, which is not 2 years. Um, so pediatrics, a lot of ward rounds, a lot of paperwork, a lot of education time as well. It's one of the departments where they really educate quite a lot. Yeah, and the dynamics between a team as an intern, I, I enjoy it. That's all I can say. It's a really, really, I don't have a problem with the job. For me, it's more about the traveling, but those are the sacrifices you will have to make initially as an intern.
And so what's kind of the ultimate goal for you once you finish your internship? What's going to be next for you?
Well, I've registered with the Australian GP training program. So they came back to me, and so this is what you can do in your intern year, because part of the new GP training program in Australia is it's a 3-year training program, and if you've done a hospital year already, they can take you as a PGY2, and they can count that year, and then obviously you have your 2 uh, uh, practice years. So in addition to the hospital year, um, you can start registering. So I want to be a GP because I want to eventually settle down in a town where there's 60 people, and I want to be the GP.
Yeah.
Okay, that's in my mind. I know that's not realistic, but that's what I'm thinking. I do like the challenge of family medicine in particular. Or just be a general practitioner. You've got patients that you see for a long time. I had a patient yesterday that I was discharged. She'd been in hospital for about 8 weeks, and I've seen her whole journey through. And she said yesterday to me, she's got no GP, and she asked me if she can be my patient one day if I'm a GP. So, these are the nice things about your interactions with patients. If you spend the time, obviously, with that patient. So with the GP training program, I've already enrolled. They sent me a letter and they said you can start the program pending on. Obviously, you have to go through a selection interview process, but pending on you have to have a general registration. So you can only have that once you finish that first year and pass your AMC2 exam.
I'm so happy to hear that. I want everyone to go into general practice. And in particular, I want people to want to do rural general practice. So
Yeah,
that makes
yeah.
me happy. Obviously, for everyone in the room, I will support you, whatever your goals are. But I always
Thank
really
you.
like hearing when people want to do that. And that's great that that program you can start it at, in your postgraduate year too.
Yeah, it's really good.
Yeah. We have a couple of questions in the Q&A box. And for those of you who are new to attending webinars, if you have questions for Dr. Thelma, please put them in the Q&A box and we'll answer them live. And if we don't get to them, we will make sure they're answered after the session. So Mumtaz wants to know, so Dr. Thelma, what would be the recommended time frame within which to try and sit the AMC after graduation? And when should we start reaching out to hospitals to see if we can apply for internships, etc.?
That's a very good question. So it all depends on the timing. You will have to. So in my case, I graduated in May of last year, and I had to wait that entire year before I could actually even approach, because the internship placements has already been taken place. So I would say put your feelers out there October, November, December. They usually have an early intake. I know from as an IMG, you can't go through the PMCV pathway, so you will have to approach either a hospital yourself via their workforce, or and I would say because sometimes there are some local interns that pulled out and they said, look, I don't want to take that, I've accepted another, and then they've had that vacancy. So don't be dismayed by thinking, if you go too early, you might be told, and I'm saying early as October, sorry, we are fully booked, we've got our interns for 2025. Or you can wait until December, and obviously after graduation, if you graduated. So I think the other graduation ceremony is now changed to July. Is that correct?
That's right.
Okay.
Yes. Even if you finish your graduation requirements, that's fine. Just the actual ceremony itself is not until July.
Okay,
But
excellent.
you can
So
graduate before then. So like, for
yes.
example, we have somebody who is finishing their graduation requirements like as we speak. Today is the last day where things are coming in for them. And then they're going to the graduation ceremony in July.
Okay, so for that graduate, I would say give yourself 3 months to sit your AMC1 exam. No less than that. That's my honest advice. So that will take you through to, and then there's a late match coming through the PMCV. You can try and attempt to contact them. Off the record, no guarantees, but sometimes you never know. There are some late vacancies available. There is a mid-year intake as well. Again, you have to be very careful with PMCV. I would advise any student that's listening to this is to contact them. Sometimes they might give you some advice on what to do. We've actually done that as well as interns starting this year, and they just guide us. But the moment you get a spot at the hospital, then you are registered with PMCV. That's the catch. Although you're an IMG, doesn't make sense, but it does make sense to me. I know it's a bit weird. So give yourself 3 months for the IMC1 exam. Yeah, so those students are graduating now. I would say try to put your feelers out there in November after passing your AMC1. So with the AMC1, you have to wait 4 weeks to get your results, and you cannot get a position without. In saying that, I was guaranteed my internship pending my results. So I'm just putting it out there. So you never know.
So we've been talking a little bit about like being a doctor and getting started being a doctor, but of course there's all this work that has to go in before that happens. So I do want to talk with you a little bit about like actually getting through medical school, and the curriculum at OUM has changed a bit since you went through preclinicals, but the clinical curriculum is pretty similar, and the general subject matter is the same. So what do you think that people need to going to personally consider before embarking on starting medical school?
Okay, realistic vision, don't have children, don't have a job, make sure you've got money in a bank account. Okay, but that's not our cohort. So unfortunately, I'm going to give you the hard version now. I think what's attractive about OUM is the flexibility. That's and affordability. The platform was designed for students of mature age. Just previously, that was kind of when I enrolled. This was in 2016, so we're looking at a few years back here. If you want to embark on this pathway, I would say make sure you are extremely structured, and also pick your battles. If you're tired and you feel like there's no point in trying to study if fatigue is a problem and family demands are in the way, which can lead to stress and anxiety. You will have to kind of communicate with your family about your expectations, and their expectations from your family needs to be negotiated, because that is also a major thing that I heard from a lot of people is, some marriages can break down as a result of this, because my partner in particular is very understanding. Thank God for that. And he did tell me with this whole thing, because we met when I started medical school, he said to me, it's like having a third person in our relationship, because I spend more time with this entity than I spend with him. And that's the realistic expectations for medical school. It does take a lot of your time. There's no way to get around the theory. You have to sit and do the hard work. There's a lot of tools out there that can help you. I used a lot of for clinical procedures and stuff, like Geeky Medics and Osmosis depends on your learning style. So I'm a visual learner, so I would like to see the process in front of me. If you're an auditory learner, you can obviously listen to podcasts or whatever you want to do. And then there's people that sit and read. I struggled with that because it is so much to read, you get sometimes lost in medical textbooks. So knowing how to read was important, knowing your curriculum, knowing your structure at whatever level. With OUM, they built from the pre-clinical platform to the clinical platform. So you go through those science platform, and obviously, biochemistry, pathology, you name it, anatomy, physiology, and then you build on that, and you build on that. That's what I like about the curriculum in OUM as well. There's a building process, and so they make it actually, if you get your foundations right, you can build on the next process, and then the next process. In your final year, approaching your graduation year, or finishing your clinical rotations, you are expected to have the knowledge of an intern, not a registrar, not an HMO, not a consultant. So just remember that, and the other thing that I can emphasize for those that still need to sit there, ask kids as well, is there's a structure to that. With anything in medical school is a structure, but safety is paramount. You cannot be a clinician if you cannot be safe. So everything you do, it doesn't matter what you do in an approach with that patient, whether it's on paper as a clinical scenario or in real, is this going to harm my patient, and is my patient stable? Those are two questions I actually answered in my head when I approached my OSCEs. And I got that very quickly out of the way. You can obviously ask for your vitals, or you can look at the person in front of you, or you can ask your examiner. But in real life, this is what we deal with. And I'm going to tell you this. I had a med call. I had to attend a med call. I was the first doctor there, and I did not know what to do.
So what did you do?
So that's an emergency call. We had a patient that basically she's got pulmonary fibrosis, and she was very hypoxic, and she was very white. She looked like a dead person, apart from the fact that she could talk, and she was really struggling to breathe. She was lying flat on the bed. We had to do a med call, and before you know it, you know what? All you need to do, just the basics, go through doctor's ABC. That's what you need to do. So that's a platform you need to understand, and then obviously the team is there to assist. And that's the other thing as an intern. Don't be scared to call a med call. I would much rather want other people to come and flock the patient than me standing there and the patient is crashing on. It's not your responsibility, it's everyone's responsibility.
I like that you mentioned safety, because that's like the main thing that we're trying to teach is how to ensure that you're going to be safe if you're out with a patient and you're the decision maker. So that is like paramount in the OSCEs, which is the objective structured clinical exam that students take at the end. But even in our assessments in the preclinical, what we're looking at is, do you have the knowledge that would enable you to be safe in patient? So thanks for mentioning that. One thing that students and prospective students are interested too is like about clinical skills. Like, it makes sense to people that you would be able to learn like medical terminology and memorize things and like synthesize things in an online platform. But like it's hard for people to understand, well, how would you actually learn clinical skills if you're part of a program that's partially online or a hybrid program like OUM? So I want to ask you how you learned clinical skills, and then I can provide some information about how clinical skills are taught in the new curriculum. So how did you learn clinical skills?
I'm lucky because I do come from a health science background. So I guess clinical skills was part of my physio curriculum, and obviously as part of a workup in a patient from a physio or rehab point of view. Now, look, there's a lot of things platforms out there that can help you with those. But my best advice is to go and find yourself a buddy and practice clinical skills on that. That's what we've done as well. I've got 3 OUM students, or well now graduates, that we worked as a team of 4. We worked very closely, and we practiced our skills on one another because the platform was a bit different when we studied medicine. So I guess the students now are very lucky that OUM has really come a very long way. And I guess it was trial and error because, things change. COVID also happened. A lot of things had to be changed in the curriculum as well. But from a clinical point of view, practice on your cohorts, practice on family members, just break it down. So, I did the box thing. So why do I need to do a neurological exam on a patient? So for example, we had a patient yesterday. I like to use examples. I'm sorry. I hope you guys like that
Love it.
because
Please
it's
go.
relatable. So we had 3 students yesterday, and for some reason, our hospital or the registrar just loves to offload the students on me. So, but it doesn't matter. I'm happy to help them. They actually make my job easier because they do all the running around and faxing and things like that as well. But yesterday, I was admitting a patient that had a Weber C fracture of the right ankle. Okay, so she's got a lot of comorbidities. So we're talking about subacute here. She had a fall. She's got a pacemaker. We're not sure why she fell. So there's a lot of things going on with this patient. Now, the patient presented on the ward after an initial admission, late afternoon. Obviously, a neurological exam wasn't part of that. And the next day, the students asked, what can we do? And I said, you know what, we do need to do a neuro exam on this patient. She's got peripheral vascular disease. She's got type 2 diabetes. She's got a fracture. So there's a lot of risk factors in her fracture not healing. And she's also got open blisters on the skin from friction of the cam boot. So why do we do these physical examinations as a student, and particularly this patient, is to make sure that we can also differentiate, understand, she's got sensation in the feet. So from a rehabilitation point of view, and also from a risk management point of view and wound healing and things like that. So I broke my clinical examinations down in boxes. So in this patient in particular, a neuro exam was paramount, okay? Your cardiac exam, cardiovascular exam, obviously you need to do that as part of a doctor. That's what we do anyway. We listen to the lungs, we listen to the heart, we look at the periphery, we look at the patient. And the other thing I also wanted to say to do a lot of cohorts is I see a lot of, on our ward we had in 1 week 2 hyperkalemia cases. On paper they should be dead. Okay, but you walk into the ward and you look at the blood results and you kind of go, should I panic or should I not panic? put that into context, but also understand that things can go wrong very quickly if someone's got arrhythmias or they've got cardiac conditions with hyperkalemia. So that's kind of all I can say on the clinical one is just practice, practice, practice. And you will have to know, everything. As a doctor, you'll have to know everything. There's no shortcuts. Sorry.
There's no shortcuts and there's no stopping of learning things. Learning does not stop when you graduate medical school. Okay, so I'll just give a little bit of information about the current curriculum, just so people know how clinical skills are taught in our new curriculum, which started in January of last year. So in the current curriculum, you do organ systems. So it starts with the general principles course, and then you take one system at a time. So next you'll take cardiovascular system. Then after that, you take pulmonary, then urinary, so on and so forth. There's 10 different systems. So in each system, you have 3 live classes and you get a set of recorded lectures as well before you attend class, so you can feel prepared to come to class. The 3 live classes are a workshop, a case discussion, and problem-based learning session. And every workshop has a clinical skills component to it. So every week you're learning a clinical skill that is specific to the system that you're learning in that session. And then once you're finished and you've done all your clinical skills, with integration of your basic sciences when you're doing your preclinical years. So we have a preclinical portion of the curriculum, then you move into what we call our clinical transition unit. So the clinical transition unit has a clinical skills course that is specifically designed to improve and enhance your clinical skills that you may need and have opportunity to practice once you go into the clinical curriculum and you do your clinical rotations. So the clinical transition unit has online clinical skills and it has an in-person workshop for clinical skills as well. And then when you go into your clinical rotations, you're obviously learning some clinical skills on site in your rotations. And then you become an intern and you're still learning more clinical skills. Then you become a registrar and you're learning more clinical skills. Then you're an HMO or you are a consultant and you're still learning clinical skills. So you start learning clinical skills when you start in medical school and you'll never stop learning clinical skills all the way through. So just some information for those of you about the new curriculum.
That sounds fantastic. That sounds fantastic. That's
so
way
far,
better than I had.
so far, so good. Something that is not dissimilar to the program that you took is that we do have a research requirement. And I wanted to talk with you about this in particular because you were not a researcher, you were a physiotherapist coming into medical school, and yet you left medical school at your graduation. You were the recipient of the Student Research Prize for your project, which I wrote down, which was the quantitative study of pain and function after total joint arthroplasty on discharge. So congratulations again on that. I got to congratulate you in person and via email, but I'm going to say it again while you're here. And because you had such a successful research project as someone who is not a trained professional researcher, could you tell our students and prospective students a little bit about doing research as a medical student?
Yes, first of all, I want to say it's not as hard as it sounds. It does take a lot of, work initially, but the writing up bit of it and, analyzing what you've done. And I can also perhaps just speak from my own experience, was quite enjoyable because I actually had a question I wanted to answer. So for me, it was a no-brainer to go and do that study. I had all the data available. And then I decided, you know what, I'm going to make my life easier as a physio and see how I can answer this question. But you don't have to go to such extremes to kind of get a research project across the line. You can also work with some, I'm not sure if that's allowed still, Professor Maguire, but I do know that OUM sometimes does allow, you can join a research of a current study being undertaken, or that was in my bits during OUM. It's not as hard. Look, just understanding research is paramount in what we do as doctors. Things change all the time. A medication that's in this year might be out of fashion next year because some new research is found, or it improves our clinical skills. But you're also, being in the hospital now as an intern, I do also often get asked about, what do you think research is saying about X, Y, and Z? So doctors do have these discussions in hospital, and you don't always have the answer, but what you can do is know where to find the resources and the information regarding that. So learning that skill is, research also teaches you that skill, because as a doctor, that's the most important bit, is finding information to assist or help a treatment plan or a diagnosis. I'm going to give another example again. Okay, we had a patient in our ward that she was admitted. She had a fall and she sustained a fracture. So I'm rotating on the rehabilitation ward at the moment. It's packed with geriatrics, and most common causes is orthopedic cases, falls, delirium, you name it. So this particular lady, she's 60 years old. She's got a high BMI, morbid obesity. She fractured her pelvis. Okay, so she came in with a simple fractured pelvis, affecting her mobility, just want a bit of rehab. But she was on no medication. She had chronic wounds on her legs, and she was undiagnosed diabetic as well. Long story short, we gave her medication. This is what doctors do. We just threw her, like, you name it, ACE inhibitors, furosemide, metformin, anything we can possibly do to get fluid off this woman and make her a bit healthier. And then she developed an immune response. Okay. And she looked like a light bulb, a red glowing. She looked like she was in the sun all day and didn't put any sunscreen on. Okay. To a point that we had to escalate it to dermatology. So long story short, I was lucky enough to done a punch biopsy on her lesions. So again, we'll get back, because I think there was a question about clinical skills, which I'll answer. So punch biopsy, under supervision of a reg. Obviously, results come back on that. It turns out she had DRESS, so it's a drug-induced rash. I've never heard of that before, but the process of liaising with dermatology was so enjoyable, because they came up with a list of differentials, so wanted us to rule out. And eventually we got there. And yesterday, she's also the patient that was discharged. She said, I'm so glad I was in hospital when this happened, because, if my GP would have given me this medication, I would have had the problem at home and I could potentially have been dead. So that's the thing with research, is I had to go and read up on a lot of skin. I mean, dermatology is a topic not really covered at the undergraduate level that much, apart from skin lesions, skin cancers in Australia, which is what you need to know for your MC, by the way. So, so this is where research comes in. There's a lot of research that you need to available at our fingertips, but you also need to understand how to interpret that. It's a very long story, I'm sure. Sorry about that.
No, I mean, what you're saying basically is that the skills that you gained as a researcher and the drive to understand research saved this woman's life.
Well, I wouldn't say it's me, but the understanding, yeah, I think, yeah, I would like to claim that, Professor McGuire. I'm happy to claim that, but
Who
I
knows
guess
what would have happened if she had been at home and taking those medications?
exactly, yeah. So it's understanding. This is, we think, oh, research. That's actually how I thought about, like, oh, this is just a pain in the butt. It's taken me about a year to do my research, but it is extremely important that we understand the interpretation of results. Also, when you do pediatrics, you have to look at your bilirubin. And you have to understand when a child is going to be jaundiced, and understand the physiological side of it, and early onset, late onset, and obviously physiological. And that's all plotted. You need to understand those graphs and how to interpret it. And guess what? You'll get asked that question: this is the reading? This is how old the child is. What do you think? What's going on here, Thelma? What's the plan? So you have to plot that. Understanding how to plot data you need to know these things. I'm sorry to burst anyone's bubble, but you do need to know these things.
And I didn't mention before, but I think it's worth mentioning that like we also don't just like toss you in the deep end. Like we do have a research director and we have research advisors that help students to choose topics and narrow things down and help them through the process of conducting a research study and of getting that into a publication. So it's not something that each individual needs to figure out completely on their own. So just worth noting if that's something that's like in the back of anyone's mind that's attending.
Yeah. Professor McGuire, sorry to interrupt you. Another thing I wanted to mention, Jessica was the research.
Yes, Dr. Owen. Yep.
Yes, Dr. Owen. Sorry, I forgot her last name. And is she still with OUM?
Yes, she's still the Associate Director for Research. And for those of you who are in the 2402 cohort, you're going to have Dr. Owen as your professor for your first class, which is General Principles.
Awesome, awesome. Can I just say, when I got stuck on my research, I had a chat to her. And what's lovely about your research team is they look at it objectively. They're not going to do your research for you, but they tell you what needs to be addressed and what's not relevant. And don't be scared to ask. And also
They won't lead you astray.
and I know
take you down a rabbit hole.
No, they won't. They want to see you pass. And also just perhaps jump onto projects that's currently been undertaken by clinicians at the moment. I was lucky enough to work with Professor Dewan on his project as well, and it was very enjoyable. Look, it's very, so yeah, there you go.
And Professor Juwan is the current dean for Australia, and you just could not find a more approachable dean. So.
Oh, he's just absolutely wonderful. Yeah.
We're just about out of time, so I wanted to ask you if you had any advice for those of our attendees who are thinking about applying to medical school. What should they do?
All right. Consider your motives for why you want to do it. It is a long-term game. And we previously discussed, obviously, knowing where you are with your affairs. I would just also advise you, don't be in denial about your current personal situation in relation to medicine, because I think medicine in particular, especially on TV, is very romanticized, you know. It's not a romantic thing, okay? It is genuinely the real hard profession where you have to put in a lot of hard work. But obviously it's extremely stimulating, it's extremely mentally satisfying, and it's also the outcome there is to look after a patient that otherwise would have been ill, or you know, that's the goal, is to look after our patients and patient care. So just know that obviously personal reasons you want to do it and professional reasons, and also perhaps my third advice is just be kind to yourself if you're in the process and you feel like this is really, really difficult. Don't give up yet. I actually wanted to quit a few times during medical school, and it was purely because of financial reasons. I didn't particularly have a lot of money in the bank floating around. So doing those, and there is a question in the group as well regarding, can you work and study? I would actually advise you not to do that. Obviously you can do what you want as an individual, but it does come at a cost. Unless you don't have a family or no friends, I would say yes, do it. But if you have a family, you've got friends and children and animals, I would perhaps, yeah, reconsider that approach.
If you think it's difficult and you want to quit, you're going to be in really good company. It's really difficult and people are here going to want to quit.
That's a very good point.
But just don't feel alone about it.
Yeah. Talk to your peers. Yeah, definitely talk to your peers and your family. You know, exam times are in particular, and I think this is the other topic before we finish. I know I can talk all day, I'm sorry. I just love the topic, but exam times, you will have to be very strict with your exam times and reducing stress. because I was caught out a few times. I've got kids and animals, but I haven't communicated as clearly as how important it was to me to have quiet time. And my children upstairs would play video games and scream at their friends over the microphone. And, then I just studied a topic and then go upstairs and scream at my kids and come down. And that's quite disruptive. I know, parent of the year, but look, this is what happens when you have
Do what you got to do.
do what you have to do. Yeah, so make sure you communicate that. Obviously, if you don't have those add-ons, as I call it, and you just by yourself, obviously you have to just create a nice space for yourself. Exam times it's a time of assessment, and it's also a time where you can actually express how good you are in your knowledge. And the outcome of that is only as good as the input and the work you've done prior to that.
Yeah. I think like anxiety about tests is a pretty common thing amongst medical students, but I like how you put it. It's your opportunity to show all that time and effort that you put in over the last little while to be able to show off that information. So I think that's a good framing for people to think about as they go into exams. And we actually do have, for those of you who are starting in our 2402 cohort, we do have a study skills and test taking strategies session with Dr. Okeke, who you met last night if you were at our meet and greet, to get you kind of started on the right track for test taking skills and reducing anxiety and all that good stuff. So we will keep that in mind for that session. I want to thank each and every one of you for joining us today and sticking around while we resolved our technical difficulties. It was great to see all of you, and for those of you joining us via recording, it was good to see you as well. And I know you'll all join me in thanking Dr. Thelma for taking some time out of her extremely busy schedule to speak with us about her journey as a medical student, as an intern, as a taker of the AMC, as a completer of research projects, and as a carer of people who have, and patients who have benefited from her expertise and her continued growing knowledge. So we really appreciate your time. Thanks for joining us today.
Thank you so much. I appreciate it. And all the best for everyone. And enjoy the process. That's all. The journey. It's a journey.
Yeah, for sure.
No worries.
Thanks, Dr. Thelma. If you sent us a question in the Q&A and we didn't have a chance to answer it today, I will ensure that all those questions get sent to our admissions counselor. We get back to you with an answer. And I hope you'll all join us for our next webinar, which is coming up on June 5th in North America, or June 6th in Australia, New Zealand, and Samoa, where we'll be meeting the Dean for North America, Dr. Crystal Boone. So thanks so much, everyone. Thanks, Dr. Thelma. See you all.
Thank you so much.
Bye.
Bye-bye.